Recording in progress.
You didn't get that recorded. Okay. I was trying to come up with a title for my chief talk, and I got to give a shout out to Brian Bader, the Burn and P, who helped me come up with this. So I want to start by going through a little of my family history. I'm a fourth generation doctor and the first woman to be a doctor in my family, so I'm very proud to carry on the Sather name as a doctor. My great grandfather, Alan Sather, was a GP country doctor up in northern Minnesota in Foston. He started the Sather Clinic, which was essentially the place where people in the northwest corner of Minnesota got their medical care. He did home deliveries, apparently did appendectomies on kitchen tables, and had a logbook of payments, which included goods like chickens. My grandfather, Bud Sather, who is pictured in the middle of the middle picture, was also a GP. He was a captain in the Army Medical Corps in the Pacific Theater in World War II. And when he came back, he also worked at the Sather Clinic alongside two of his brothers who are also doctors. He married my grandma Betty, who I pictured here, who was a nurse. And a number of women in my family ultimately became nurses. From the 1900s to the 1960s, women made up less than 6% of doctors in the US. Even though the American College of Surgeons admitted their first woman in 1913, still in the late 1970s, women made up less than 2% of the college. In the 1970s, there was an increase in women applying to medical school, partly because of more spots, the women's movement, the baby boomer generation, and ratification of the Equal Opportunity Act. It was around this time that my dad, in like the 70s, 80s, went to medical school and residency to become an orthopedic surgeon. 4 out of the 48 people in his Duluth medical school class were women. Maybe 2 out of the 15 in his general surgery preliminary program, and 0 out of 10 in his orthopedic surgery program were women. By the early 2000s, women made up about 24% of physicians, and now medical students are around 50-50 men and women, slightly leaning towards more women. And general surgery residents, although difficult to find the exact number, is somewhere in the 34 to 40% range, depending on what sources. We have made great strides over the last 120 years, but like in everything, there's always room for improvement. So today I'm going to talk to you about women in surgical training specifically. Specifically the discrepancies in trainee autonomy, performance, and discrimination based on gender. I'll then go through some solutions. I'll then continue to talk about myself and thank all of you. There are actually a decent amount of studies that have looked at gender differences and autonomy of surgical trainees in the operating room. I'll talk about a handful of them and won't go through them in a ton of detail, but we'll highlight the key findings. The study on the left, published this past year, included 4,100 trainees in a variety of surgical specialties, with the majority being general surgery, and their number of cases. They found male residents had more cases, and when they looked at basic and complex cases, which were specifically considered to be autonomous cases, male residents had 60% more than their female counterparts. The study in the middle from 2020 showed similar total case numbers between the two groups, but fewer autonomous cases for females compared to men. And then the study on the right showed no difference, but found that female trainees perceived themselves to have less autonomy than males, rating themselves lower than how their attendings had rated them. Here are 2 more studies that showed similar results. The left study had 400 residents and 500 staff use an app similar to Simple to collect evaluations of operative autonomy. They found that female residents received less autonomy. Level of training and case complexity were the largest predictors overall, but when these were controlled for, when controlling for those factors, the gender-based discrepancy still existed in most PGYEs listed. Finally, the study on the right from 2023 is one of the most interesting ones I found because it was both a quantitative and a qualitative portion. The quantitative portion was from a post-ABSITE survey. So quick plug for the residents to take the survey at the end of ABSITE so we can get helpful data. And then a qualitative portion was obtained using focus groups of resident and faculty to try and come up with reasons behind the quantitative results. So over 5,000 residents responded and 82% reported appropriate autonomy. Appropriate autonomy was associated with lower rates of burnout, suicidal ideation, and attrition. When they adjusted for various resident and program characteristics, women were less likely to report appropriate autonomy with an odds ratio of 0.81. This is especially concerning because residents that were satisfied with their level of autonomy were also more likely to report satisfaction with work-life balance, workload, and job demands, faculty engagement, and also resident camaraderie. The qualitative portion I thought was particularly interesting because it contains a number of quotes from the residents and faculty participants giving insight into this. A recurring theme was commenting on the systemic barriers of gender stereotypes. For example, women may be more critical toward themselves, and this may come off as being less confident. Or on the other side of the spectrum, how assertiveness in men is positive, whereas in women, it can be seen as argumentative or overconfident. Other systemic barriers that were brought up include that attendings may be driven by RVUs, thus more pressure not to be slowed down by a resident, the legal perspective of autonomy compared to days of old, greater complexity of modern surgery, and patients being more medically complex. One of the points that I found particularly meaningful was since autonomy seems to correspond to a much more overall positive experience in residency and is associated with more job satisfaction, the question of how can we invest more time and effort in residents that need more help in the operating room rather than just take away the instruments if they're struggling, for example. Whether women truly have less cases overall or just less autonomous cases is still unclear since this data is based on perception, or if women just perceive that they have less autonomous cases. One thing that came up in multiple studies and that I found for myself is that women may be more particular with case logs. For example, logging first assist when someone else may log surgeon junior for doing the exact same thing. Or logging one CPT code for a patient case rather than logging different CPT codes over multiple entries for the same patient, which you're not technically supposed to do. Either way, doing a bilateral inguinal hernia and logging it as two separate entries, for example. Either way, perception molds confidence. So regardless of whether women truly are less autonomous in the attending's perspective, or if it is just in their own perspective, if these female trainees ultimately have less confidence because they think they're doing less than their co-residents, this will negatively affect their job satisfaction and may increase burnout. It also may plant seeds of doubt in their abilities. One way to maybe get around this is to have very clear graded autonomy. For example, telling a resident, it is expected that you can, at this level, can safely take the gallbladder off of the cystic plate. Or if a resident has instruments taken away from them, maybe clarify that typically residents of their level don't even make it this far. Or on the flip side, if they're struggling, tell them, be honest with them and tell them exactly what they need to do better. The next thing I looked at was resident performance. The first study on the left from 2020 looked at milestone assessments of over 4,000 trainees. At the beginning, there were no differences between men and women, but by graduation, women received lower scores overall and across multiple subcompetencies. Although only a difference of 0.06 on a 5-point scale, this was statistically significant. They once again commented on the confidence gap and pointed out that confidence and competence can be confused sometimes, can easily be confused. The middle study from 2022 found no difference in faculty evaluations, but similar to the earlier studies on autonomy, female trainees perceived themselves to be 0.29 points lower on a 4-point scale, which was again small but significant. Finally, the study on the right, using Simple to look at how trainees rate their performance in the operating room, found that female trainees rated themselves lower than their male counterparts and also reported more supervision. They found similar results when looking at the Simples that were filled out by the attendings. Finally, when they looked at case complexity combined with female gender, that was also associated with more supervision. Even though these are all pretty small differences in scoring, if women are continually rated lower, or at least perceive themselves to be rated lower, similar to having less autonomy, it will be difficult, it will affect their ability to establish self-efficacy. Now, looking at gender differences and discrimination and burnout. Both of these studies used a post-ABSITE survey, so again, the plug. The study from New England Journal of Medicine is another, so used the post-op site survey. Over 7,000 residents responded. 65% of these 65% of the women reported gender-based discrimination compared to 10% of the men. And of the sources of discrimination, the majority of them were patients and family members, which honestly is not surprising. But where I think we can see a lot of improvement is with the quarter of discrimination coming from nurses and staff. There have been numerous times during residency where myself or other residents have talked to me or witnessed it about female residents being treated differently by nursing or OR staff compared to our male co-residents. Our male co-residents have also noticed this and commented to us. It's one of the reasons that we were worried a couple years ago about the QR codes that were being placed at the nursing stations. In this study, they found that mistreatment was associated with burnout, and although women were more likely to report burnout, when this was adjusted for mistreatment, the burnout, this difference disappeared between men and women. The JAMA study on the right also was a post-op site survey specifically looking at various categories of discrimination. The most common category was being mistaken for a non-physician, which many of us have had happen to us, occurred in 77% of women and 4% of men. Men, the most common category of discrimination that they experienced was negative reactions to having kids or childcare needs, which was 10% of them. Women, on the other hand, that happened to 40% of them. So even though it wasn't the most common, it was still a significantly more amount than compared to men. There's obviously considerable program level variation in rates of discrimination and harassment, but it is important for people to speak up if they see something and make sure to stick up for their colleagues around them. Finally, where are we at now? Thankfully, women are more and more represented in not just medicine in general, but also surgery. It is important to be aware of the biases we may have. This paper talked about the female stereotype of being communal or kind, dependent, and nurturing, whereas the male stereotype is agentic or logical, independent, and strong. Women with communal traits are often deemed less competent, whereas if they portray some of these more male traits, may be seen as overconfident. This paper once again brought up the well-documented confidence gap between genders, where women project less confidence for the same level as men. Imposter phenomenon, as Hannah talked about a couple weeks ago, is also more common among women, and all of these are associated with burnout. We talked about some training-related issues earlier, and I won't really touch on leadership and compensation, but these are all areas where we have made great strides, but still have room to grow. So what should we do? I'll just focus on the first three, but all of these categories are obviously important, and this paper goes into a lot more detail and includes way more solutions if you want to check it out. So with regards to bias and harassment, I don't really find endless online training particularly helpful, but what I did think would be helpful would be some sort of training in dealing with difficult patients. Since these are the majority of instances of discrimination or harassment, how do we say something without alienating this patient that we're trying to help? How do we still take care of them, but not just ignore bad behavior? Also, empowering bystanders to speak up when they see something. If, for example, a circulator is refusing to log a patient into the case log or answer pages for a particular resident, maybe say something and ask why. With regards to training environment, having set standards of autonomy and goals certain levels of residents should have would be helpful. We have something similar to this, but maybe an easy access resource with some examples or clear messaging among staff would be a start. Also, now that simple is mandatory for graduation, we should look at these same metrics that they did in these studies and see if there are differences in our own program with regards to gender or other areas, and see if we need to make more personalized adjustments. Finally, with regards to mentorship, I think there are a plethora of staff from a variety of backgrounds to reach out to at this program who would be willing to be mentors and who are amazing to train under. It's one of the things that I talk about on recruitment day each year for the interviewing students, and I think is a major strength of our program. Across numerous studies, even when objective differences are small or inconsistent, Female surgical trainees report and often receive less operative autonomy, rate their own performance lower, and experience higher rates of discrimination. These gaps matter, not just as metrics, but because autonomy and perceived competence are linked to confidence, job satisfaction, and burnout. The data also suggests this is not simply an individual issue, but a systems-based issue. Proposed solutions, like I said, include setting transparent expectations for graded autonomy, giving precise and actionable feedback, supporting residents when they struggle rather than just sidelining them, and actively addressing bias and mistreatment in real time. By doing these things, we can create a training environment and continue to create a training environment where all residents develop the confidence and skill set they need to thrive. Ultimately, it is to train better, more confident surgeons and strengthen the culture of our profession as a whole. I often think of how grateful I am to be training in this day and age rather than 30, 50, 100 years ago. And I think of people like the first woman to be accepted to the American College of Surgeons in 1913, who had to be a trailblazer. And I'm grateful that I'm now training in this day and age. We've made such great strides as a profession with regards to equity, and I look forward to seeing the continued improvements and to see this next generation of surgeons rise through the ranks. This next part will be a personal reflection on me more and more of my story. So I was born to Sandy and Jay Sather. Like I mentioned at the beginning, my dad was an orthopedic surgeon, and this is a picture of my brother and me at his clinic, or visiting him at his clinic with a glove balloon. My mom was a PT and then became a stay-at-home mom when my sister Kelsey was born. I owe her a world of thanks since she would bring us around to all of our many sporting events, violin lessons, and wasn't afraid to travel the world with us as a single mom. This is a picture of us in Tanzania on the right lower one, left lower. And then this is a picture of me with my grandparents, her parents, seeing us off on a violin trip to Spain. My mom also has been so incredibly supportive of me throughout residency, for which I'm grateful. My siblings and I are really close, and I'm so lucky to have these built-in best friends. I don't think it's advancing. I think it's frozen. But while he's fixing it, we were in kind of this intense violin program growing up, which isn't showing, but that's okay. Where we would go to lessons like twice a week, and have frequent recitals. We traveled the world together, and there were a couple pictures from our yearly Halloween concerts. That's okay. And then I'll still play at random events like weddings and get together with my siblings, which is probably my favorite. I don't think it's still not advancing. That's okay. It's just skipping slides. But so I went to Concordia. That's going the wrong way. In Moorhead, where I ran track and cross country, and then this is for med school, so it skipped. And then I was also part of an orchestra until my senior year. I was going to give a plug for the Concordia Christmas concert, which is this beautiful choral and orchestral concert that actually comes to Orchestra Hall every beginning of every December, if anyone wants to check it out. And then there was also a picture of when I was in college. It flooded 2 of the years, and so we actually missed 2 weeks of school to sandbag or be evacuated from the city. And it was really inspiring to see the entire city come out and all the college students from the 3 major colleges there come out and sandbag to save all these houses and neighborhoods from being destroyed by the flood. After college, I went to Boston University where for medical school. I loved Boston and loved med school and made a lot of my closest friends there, and also met my now husband there. This is a bunch of us at match day, which I so vividly remember, and I'm so grateful that I matched here in Minnesota. Interestingly, most of us in this picture ended up going into surgery of some form. This is my dad hooding me at graduation, which was especially meaningful to me. I had to include our broomball team, and then I wanted to include this picture of me with Dr. Jennifer Sang, who was, she's a surgical oncologist and was the chair of surgery at BMC at the time, and she was the first female chair in Boston. Kind of random, but I had to include some quick history. that I'm proud of for having gone to that school. But BU is often considered the first medical school to graduate women since they merged with New England Medical College in the 1870s. Rebecca Lee Crumpler is the first Black woman to graduate medical school, and so she is a major part of that history and also for history here in medicine. She graduated in 1964, which was a year before the Civil War ended, which is crazy. And then she initially practiced in Boston. And then after the war, she moved to Virginia, where she served freedmen and women. Like I said, I met my now husband, Christian, in medical school. He came back to Minnesota with me, thankfully, and has been the biggest support for me throughout residency. Special thanks to him for taking care of me. He would call me his Tamagotchi during particularly busy rotations, since he would literally feed me and keep me alive. He also encouraged me to pursue the Burn Fellowship when I was figuring out what to do with my life, and Dr. Miyake was texting me. And now here I am going into Burn. So I'm very thankful for that support. This picture is from when my sister and I ran the Twin Cities Marathon my first year of lab, and he worked it. I would jokingly call them both my two number ones. And now my new number one. This is Rich. He gets his own full slide. I did my last call shift the night before. I ended up being induced a bit earlier than planned. So it's like he knew my checklist that I had to get through. He is the joy of our lives, and we are so obsessed. One of the things that came up in a number of the papers that I was reading was parental leave and having children being a reason for discrimination or being treated differently in some way. One of our family friends who actually graduated from residency here back in the 80s got 2 weeks when she had her kids, which were her 2 vacation weeks. Her co-residents were also mad because she had her kid over the holidays and they thought she timed it to get that time off. I say this because A, obviously things aren't perfect, but this is yet another instance where I am so grateful to be training in this day and age when there is more parental leave and vacation and people are so much more supportive. My co-residents have been amazing and really flexible with me trading call shifts with them throughout the year and then covering surgical oncology while I was gone. Also, special shout out to Ted and Treyster, who let us make kind of a crazy call schedule so I could front load my call the last block before leave. Thanks to Michelle and Miranda, the other program moms in the program I reached out to when I came back. They were really helpful and encouraging. And then also thanks to the Surgeonc team, who has been really amazing and supportive of me coming back. Dr. Wee and the HPB staff, especially Dr. Brower. So thank you. Also, Eileen gets a special shout out since she was the 3 with me and she made the transition so smooth and enjoyable. On to residency. So I remember last year when Chesney gave her chief talk, and she had so many pictures. I made a goal to take more pictures, which didn't really work. So I don't have that many. But I had to include this one, the second one, where Amra was our chief. Lauren isn't in it, but she was the intern on service when I was the EGS2. And then Christian, you can barely see in the corner in his black jacket. He was actually the family medicine intern that happened to be scheduled with me as his 2. Got to give a shout out to my class from the beginning and now the new class graduating. Seems like so long ago, but also just yesterday that we were interns or second years during COVID, during our Zoom happy hours. You guys have made residency a lot better, and it has been an honor to train alongside all of you. Also, special thanks to Alyssa, who has been an amazing co-admin chief, and I'm so glad I joined our program. My first academic development year, I worked with Dr. Beelman, and I want to give a special thanks to him for mentoring me, teaching me, helping me stay on top of things, and bringing me to Uganda with him. I also want to specifically thank him for encouraging me to follow my interests, which ended up being burn and meant that I was not going to do the originally planned 2 years with him in his lab. I really appreciate him making what turned out to be an interest at the time and now my future career a priority. During this year, I also worked with Dr. Brunswald and Dr. Luschek, so I wanted to specifically thank them as well. My second academic development year, like Dr. Miyake said, I did the Burn Fellowship at Regents Hospital. Between Dr. Miyake reaching out to me and Dr. Mel McCormick, who was the fellow my 3rd year, I ended up pursuing a field I knew nothing about coming into residency, and then from intern and third year and call had become increasingly interested in. Although chief year has been pretty great, I think of my burn year as the best clinical year of my life and is when I discovered my passion for burn. I am so appreciative of all the teaching and mentorship from the burn staff, Dr. Miyake, Dr. Lacey, Dr. Bennett, Dr. Rogers, along with Dr. Moore during residency, and Brittany, Brian, and Danielle, the burn surgery APPs. I'm so glad to have ended up in this field and with this group. So this is a little more personal, but Christian and I actually ended up doing multiple rounds of IVF, which worked, thankfully, because we now have Rich. And it was honestly a really difficult time in our lives. And for a while, I was pretty down and felt pretty lonely. I actually ran into a resident at the clinic in another specialty who was going through the same thing. And she was so supportive, and having her to talk to through this about everything made a world of difference for me. So because of that, I try to be pretty open about this because it was so hard for me. If there's anybody that is ever thinking of doing IVF or going through it, or just has questions about it, I'm always happy to talk to you or just listen to you vent, whatever you need. It is definitely not conducive to residency or even a job because of all these last minute appointments that you have to do that you find out 1 to 2 days before. So I want to specifically thank the Methodist crew, since I was there for a large chunk of it, especially Dr. Bella Dennis and Shannon Stevener for their support, understanding, and kindness through all of this. They seem to very frequently be on call with me when I'd have to step away for these appointments. I also want to thank the Region's vascular team, Dr. Rosenthal, Barbado, and Dr. Wynn, along with the Region's colorectal teams, Dr. Brisser, Dr. Armstrong, and Dr. Wolpert, since I was on their services and working with them a lot during these times. And they were also really supportive and flexible with me. To the education and administrative office, Jessica, Sarah, Michelle, Amanda, thanks for working with Alyssa and me this year. It has been great. Dr. Combadine, it was so great working with you on MIS, and I also want to thank you for your support, for all of the residents, for your leadership, and for being so supportive of me when I was 7 months pregnant on MIS during your adrenalectomies. Dr. Kendrick, I don't know if you're online, but you texted me this morning. I appreciate all you do for the residents and how much you care about us. It is really evident, and it has been an honor to work with you this year as admin chief. Hopefully we'll have an EGS week together since I'm on that now. Dr. Brunswald, special thanks to you for matching me here to begin with and for working so hard as a program director my first few years and continuing to work so hard to improve the residency. And then Dr. Meyer and Dr. Davis, thank you for trying to working towards continually improving resident training and education. We appreciate the hard work that you put into training us. There are so many more thank yous and pictures that I could put up between the staff at the U, the region staff, the Methodist crew, the attendings at North, the VA, the APPs, the residents. But I just want to say a general thank you to everyone for training me and teaching me what it is to be a surgeon, and for making me grateful that I'm training in this day and age in this program. So next steps, like Dr. Miyake said, I'll be doing the Surgical Critical Care Fellowship here at the U next year, and then following graduation from that, I'll join staff at Regents as one of the burn surgeons. Thank you. Dr. Combadine?
That was great. Question for you, as you extrapolate forward in terms of the parity in the training, is there disparities in hiring, do you think, for staff positions?
A lot of the data was from like recent, or I guess a lot of the data about hiring and stuff like that was a little older compared to a lot of this trainee data. So I would hope that that trend would continue. I didn't comment on, in that last paper, I didn't comment on like the leadership aspect, but there are obviously less women in leadership positions, but I think as residents and surgeons continue to rise through the ranks, that will change as time goes on, and hopefully it doesn't take 100 years again. But I do think that things are hopefully working towards parity in all aspects, not just training. Julia?
I'm glad you mentioned imposter phenomenon because that was the first place my thoughts went when you were comparing the autonomous cases and logged cases between male and female trainees. How would you recommend, well, one, do you see any way of studying that from a research perspective and quantifying whether that's a factor? And two, how would you recommend trainees go about I guess objectively assessing their role in the case and logging perhaps more accurately or giving themselves more credit than they might otherwise?
Yeah, I think for the first part of trying to quantify this, like in so many of these papers, it's based on perception. So I guess other than like having like AI data driven videos of cases and showing like you did this whole portion, I think a lot of it still, which could be very realistic in the coming years, a lot of it still would be based on perception. But I think that it's important to, as senior residents and staff, to just be very clear with residents. And I think some attendings do that really well. Like a lot of us bring up Dr. Brown Methodist, for example, who at the end of every case asks what you did well, what you think you can work on, and then gives you real-time feedback. I think for me, Hannah's talk really struck home with me a couple weeks ago with imposter phenomenon, and I think I'm harder on myself because when I think of a case and then hear another resident talk about that case, in my head I'm like, oh my gosh, I did not do that, or I can't imagine doing that. But then when I talked to the staff, they were happy with like what happened, like the events of the case, and had no concerns. So I think a lot of it is also just needs to be really clear communication with staff and senior residents, working with residents in general and juniors to let them know that even if you're feeling this, like, just so you know, the program thinks you're doing great and progressing appropriately. Thanks. Dr. McCaffrey.
As we progress through our careers, we take on more responsibility for people behind us. What would you say is maybe the top one or two takeaways from bystander training that you plan to implement as you become a fellow and you're leading a resident team, and then later when you're a staff and you're leading a resident team and a fellow team, and like you're technically sort of responsible for your APPs as well? Or some takeaway points that you are feel will be useful advocating for the women in your programs when you witness gender discrimination or trainee discrimination?
Yeah, I think one of the number one things is just talking to that resident or whoever it happened to, and letting them know that that comment or whatever did not go unnoticed and that it's not okay. Often that's not appropriate to do in the moment, like if it's a patient or something, but at least afterwards making sure to say something and not just like brushing her off to like quickly, hurriedly go through rounds, which I still need to work on. The other thing I think with regards to bystander training is like in the operating room when definitely see, as people become more senior or as staff, like say something if there is some inappropriate comment or like the example I gave about the circulator refusing to put residents in the case log, but the male counterparts, they have no issue including them. Like point that out, say something, and you don't have to do it like rudely, but just like ask why that is, to maybe bring attention to it, especially as staff, because staff have a lot more power than residents do. Dr. Acton?
And I really appreciated the talk, enjoyed it a lot. They add a little history thing for something that I was immensely grateful for. When I started in this program back a few years, we're in the Jack Delaney conference room, and Dr. Delaney referred a story to me when I was a second year at his house at a party, that he was the very first resident that came to this program married and had children and was not forced to live in the hospital. And Owen, being a good Christian man, was not going to force him to get divorced, and they bought a house, the department did, where the visitor ramp now sits. And Owen had a special phone line put into that house that they could call him directly from the hospital. And that's where Jack went when he was on call, and would run back to the hospital if he got called and those sort of things. So changes do come that affect
Yes.
all of us. So, but it comes us talking up and speaking up, as you
Yeah.
said, and keep moving forward. So when you fast forward 30 years to when I started, I was really grateful that Jack spoke up, did it, because in the back time, men weren't even allowed to be married. That if you were married, you weren't even given an interview for your residency. Many men would go without their wedding rings on and hide the fact that they were married for several months into their training, so they wouldn't be forced to get divorced or abandon their spouses.
Wow. That's crazy.
Yeah, absolutely.
Another reason to be grateful for everyone to be training today.
Yeah, he's not buying anyone else, he said. But
I'll
they
take a
rented it back
house.
to him. They forced it,
Maybe
rented
St.
the
Paul,
apartment,
yeah,
rented
but
it back to him. Yeah, correct. But an interesting little history thing, just
Yeah.
since we're in the Jack Delaney conference.
Yes, yeah.
I have a message from Dr. Kendrick. It says, I remember doing my first case at the U with her and Amro and thought she was so awesome and engaged as a second year. She really set the bar for how awesome residents are here. It's been amazing to see you grow through the years and become such a powerful advocate and leader. Thank you for all you've given to this program and your fellow residents.
Thanks, Dr. Kendrick. I also remember incarcerated umbilical hernia in a cirrhotic.
You case.
Case.
Yeah. Made a tea up. Good to see you.
The thing that comes on my desk.
Something that
Oh, thanks.
So we'll go get started a little bit early since hopefully we can give you some time back, everyone's favorite phrase. So I started out undergrad as a bio pre-med major at the University of Pennsylvania, and I took about 3 semesters and a botany class to make me think maybe that was not the right path anymore. And I happened to fall into a linguistic anthropology course and thought, oh, it's the best. Anthropology is so cool. And I switched out of biology and became an anthropology major, and actually graduated as an anthropology major, having completely given up on medical school. And yet here I stand many years later. And it was actually also anthropology that brought me back into medicine. I spent a summer doing ethnographic research at a community in Guatemala, and I remember thinking how interesting it was and how much I enjoyed it. And then also we were in a hospital working with physicians, and I thought, oh, what are they doing? And so I've always been interested in anthropology since then, and how that intersects with medicine. And so my talk today is anthropology and the surgeon. I promise I won't mention actually when the spirit catches you and you fall down, which probably every anthropologist who gives a talk within a hospital mentions. But we'll kind of get started here. So just general overview. So anthropology, right? It's the study of humans, of human cultural artifacts and culture. But specifically, there's archaeology, which is human material remains and cultural artifacts. There's physical or biological anthropology, which is much more closely related to biology and genetics, looking at biological variation, skeletal remains, and genetic data. And this is actually what I focused on when I was an undergrad. And then there's linguistic anthropology, examining human languages, structure, history, and how that relates to culture. And then there's the broad category of cultural anthropology, which is what most people, I think of when they think of anthropology. And that's generally thinking about the study of human societies, their associated customs, social systems, beliefs. But this is a traditional 4 quadrants of anthropology that were developed by Franz Boas in the 1800s. So generally, you think about anthropology, you have to think about what is culture. And so, again, in the late 1800s, E.B. Tyler came up with this idea of it's a complex whole. It includes the knowledge, the beliefs, the arts, morals, laws, customs, all the capabilities and habits that are acquired by people, which I think is which is a broad sort of description, but I actually really like Kenneth Guest, his definition, and he talks about a system of knowledge, beliefs, patterns of behavior, artifacts, and institutions. And he talks about how they're created, they're learned, they're shared, and they're contested by a group of people. So they encompass your entire way of life. It's not just the material goods, your artistic forms, but the beliefs, the knowledge, the patterns of behavior. And you can think about how that's contested by people. I think that's an interesting thing when we think about culture. So culture is learned, right? There's a term in anthropology called enculturation, and that's the process by which culture is transmitted to us or among us. And there's a lot of evidence that culture is deeply embedded within human evolution. And so it can make culture feel natural. It's sort of the soup that you swim in as a person. And so I think the other side of that is that you can be a part of a culture that you don't agree with or even claim. And so I think sometimes you can think about that as a resident, that you exist in a culture that might not always feel like it fits you. So it's contested. There can be arguments about the things that people share. And then finally, there's the role of human agency and the question of there are differences in how people are able to influence, contest, and enact the culture that they inhabit. Again, I think as a resident, we exist in something that you could call culture that we have variable abilities to influence, to contest, and enact. But culture ultimately is dynamic, right? It's changing and it's being modified by people within it and from outside as well. So the question is, do surgeons have a culture? Is there medical culture? I think everyone agrees there is. Do surgeons have their own culture? And so there's 6 aspects of culture. It's learned, it's taught by someone to someone else. Usually we think about it as a parent to a child, and that's enculturation. And I'd argue that if you watched a resident interact with a medical student, if you watched a senior resident interact with a junior resident, and staff interact with residents, there's a culture in surgery that's learned. It's also shared, right? So there's group norms, there's things that ought to be done, and there's values, these things that are true, right, and beautiful. And certainly we have that in surgery. We don't let consults sit until the morning, right? We stay until the work gets done. We don't abandon our patients to be cared for by another surgeon or another physician, right? Those are shared group norms that we've learned over time. It's symbolic, so it creates a meaning for us. It's a story we tell ourselves about ourselves. And so I think, one of the shared symbolic aspects of what I would consider surgery culture, we have an idea that patients allow us to take care of them in this very intimate and different way than many other physicians. And so we develop a special relationship with them. And there's this level of trust that we can't portray. There's this symbolic thing that's happening when you cut a patient. And I would argue that that's a part of the culture as well. It's patterned. So our practices make sense within the culture. It's an integrated system, and that changes in one area create changes in other areas. How do you scrub in? how does a service run, right? Those are all things that are done in a very patterned way, and you could probably go from I would argue you could go from one hospital to another, and that those things are very similar. And I think one of the other things we can think about is sort of, consults are run up the chain of command in a very specific way. And if that practice changes, it creates a very specific change in the rest of the sort of culture of that you're working in. And then culture's adaptive. It's a way that we adapt to the world, and sometimes that can be maladaptive in the long term. And I think if you look at a residency, the way things are changing, hospitals are changing, the way we take care of patients, all of those things require us to be adaptive and for us to adapt our surgical culture. And then changing, culture's constantly changing and transforming. And I think some of the talks that we've had this week, including Anna's show, that change aspect of our culture. So I would argue that surgeons specifically have our own culture. I think medicine has a culture. And so I think those are things to think about. So then thinking about surgeon culture, how do you define that, and how do you think about that individually? So you can think about it in opposition to an other, right? So the patient as our other, we're well and they're ill. Sometimes we think about it as we're educated, we're knowledgeable, and they're not. A reliance on science or medical knowledge versus a reliance on a subjective experience. So we can think about it in opposition to other physicians, the internist. Surgeons act, internists think. Surgeons fix things and internists manage things, right? So they're sort of traditional ideas of surgery, but I think they still are a common way to think about ourselves in opposition to another. Or the non-physician, the nurse. I'll leave that one alone, but it's because we think about ourselves as others, or as we think about others as others to ourselves. So I think that dichotomy contributes to how we think about ourselves, but I think it leaves a lot unsaid about the complexity of our culture. So the surgeon culture, the surgeon as a healer, right? So surgical costumes and garb, right? There's different garb as a healer. There's this ritualized cleaning, right, that we do. We scrub at the sink for 3 minutes, and we do 30 seconds, or 10, we do 10 swipes on each side of the 4 surfaces of each finger, and then your hand and your arm, right? So there's this ritualized cleaning. There's sacred spaces. Patients come to us, and we practice in these very specific spaces. The ill come to us and ask us for help, right? We don't go to them anymore. There's personalized, specialized instrumentation. It's, you could think about Dr. Jensen's instrument, right? Or his headlamp, or, here's me with a DeBakey and a needle driver. Well, that's my specialized instrumentation as opposed to the specialized instrumentation of the healer down here. And then there's certainly a role of placebo effect. And I think we all agree in what we do. Surgery there have been many studies that demonstrate the placebo effect in surgical patients, orthopedics particularly, sham surgeries for arthroscopy and other things like that have been shown to create just as much an improvement in patient outcome scores as a real arthroscopy where they actually do something. So I think we sometimes talk about that in different lysis of adhesion situations, things like that. So I think we can think of ourselves as a healer in a tradition of healing over time. Certainly, I think about ritual in the operating room. So Pearl Katz did this really beautiful ethnography of the operating room in a hospital, and she actually stayed and observed into this ethnographic research for 6 months. But I can only imagine what that was like, watching 6 months of the bustle in the operating room. But she talks about these standardized ceremonies that are expressive of symbolic, sacred, and non-rational behavior, not predominating over practical, technical, secular, rational, or scientific behavior, right? So that's what a ritual is. And rational and technical acts can be part of that ritual behavior. So she asked the question, do these elaborate rituals and technical procedures manifestly performed to prevent infection, right? That's why we're in the operating room, serve a particular separate function. Okay, and she talks about this idea of separating clean from dirty as this like key aspect of surgery, and it kind of governs everything that we do in the operating room, right? All the activities, the spatial organization of the room, the objects, the costumes, and the rituals in and of themselves. So you've got isolated areas where the surgery happens separate from everywhere else. We restrict the area from to those in this proper costume, except the patient who we put in their own separate costume to identify them as the patient and have them stay in their own role. And so does that give us the autonomy to act and participate and enable them to function in these, what she calls these circumstances of ambiguity? And so I would argue that we use the ritual of the operating room to separate us, to create a boundary of kind of discontinuity of the operating room from the outside. And that's part of the ritual. And creating that boundary contributes to a particular mental state that allows you to participate in things and activities that would normally provoke really strong emotions, and instead allows us to sort of act dispassionately, right? So we use this construct of clean versus dirty to construct the reality of ourselves as surgeons. And I think that's all part of the ritual and the culture of surgery. So, and then if you think about what is our culture in our own words, and so this isn't an anthropology paper, but this was a study doing semi-structured qualitative interviews with surgeons and trainees at a level 1 trauma center. And they talked to surgeons of all ranks, and they looked at them and they kind of broke them down to categories of experience versus early career. And they described these 7 categories that impacted surgical culture, and they broke them out between those 2 groups. And there were a lot of shared themes like patient-centered care, the importance of hierarchy, high standards, and the usefulness of meaningful work. But there was also differences in how early career trainees and early career surgeons and more experienced surgeons talked about surgical culture. And early career surgeons talked more about themes related to personal well-being, specifically, whereas more experienced surgeons talked about professional accomplishment. So I think all that's to say that in many ways we have a shared culture in surgery, and that allows us for aligning expectations, but there's also a lot of dichotomy in how we think about things, and there's, as we know that culture changes, we have to think about when there's misalignment in what our definitions about our shared culture is, because that can result in miscommunication, difficulty with interpersonal reactions. And so this paper specifically talked about trainees or junior faculty and senior faculty, but I'd argue that you can extend that also to patients and how we can think about a lack of shared culture and how we interact with patients. So I promised I wouldn't talk about When the Spirit Catches You and You Fall Down, though if you haven't read it, it's a really beautiful book, but it's sort of been talked to death. But surgeon culture can also be described as a Western biomedical culture, right? We apply biological and physiological principles to clinical practice. And there's sort of 3 core commitments of Western biomedicine, and those are that health phenomena have to be understood in terms of a physical, a biochemical entity and process, right? We use experimental techniques, and that's the preferred way to kind of gain and assess health-related knowledge. And then ultimately that human bodies are best understood as a collection of subsidiary parts and processes. And that's distinct from other medical traditions like traditional Chinese medicine, Ayurvedic, homeopathic, or chiropractic medicine, where often the human body isn't thought of as just a collection of subsidiary parts and processes, where experience rather than experiment can sometimes hold greater import. So ultimately, I don't think any of these sort of ways of thinking about surgical culture really define that culture, but I think we can use them as frameworks for how we think about ourselves and our relationships to those that we work with and who we care for. And so I'll just finish up with a I'll kind of swing back to anthropology a little more formally, and hopefully end with something a little bit more practical. So anthropology evolved originally from sort of an ethnocentric field, and with a lot of Western ethnocentricity. And then in the early 1900s, cultural relativism became much more in vogue. And then into the 50s and 60s and 70s, there was this idea of postmodern subjectivity. So, and that's the idea that that the knowledge, including the knowledge that's gained by the anthropologist about his or her subject, is kind of shaped by the researcher's own biases, by their own viewpoints and lived experiences, and that ultimately the culture being studied and the anthropologist are shaped by those. And so there's no detached objective truth to be gained. And so I would argue also that that's used in ethnography, but we can also think about that in surgery. If we have our own culture where we do things that aren't always objectively true, then if we think about things with an air of subjectivity, that can kind of change how we interact with our patients. So again, manifesting subjectivity in ethnography requires explicitly addressing the researcher's background, doing collaborative research and co-producing knowledge with participants. And it also requires the critical engagement with the political and power dynamics embedded within cultural representation. So it's can be a little bit confusing, but to me, it sounds a lot like how we work to think about culturally competent and patient-centered care, right? So perhaps we make a conscious effort to be aware of the biases and the lived experiences that we come to patients with when we first meet them, when we talk about their illnesses, when we talk about what we recommend for treatment. If we think about working collaboratively with patients and working to co-produce shared knowledge with that patient, with that family, about what's happening to them, and being cognizant of the cultural context all of us are bringing to the table when we make decisions about how to take care of patients. And then being less afraid to kind of engage with the political and power dynamics that exist within patient interactions, I think is another way that we can think about utilizing subjectivity in the way we take care of patients. So Arthur Kleinman, he's a psychiatrist and he's a very famous anthropologist at Harvard. And so this kind of all wraps up in, I really like what he developed as his explanatory model. And this is a way of helping the practitioner understand things about a patient and about the interactions they're having. So it helps you understand the patient's belief about their illness, what kind of personal and social meanings patients attach to their conditions, what are the patient's expectations about what will happen to them, and then what you will do as the provider. And it also helps you understand their own therapeutic goals. And so I'll end here with he devises this concept of 8 questions that you can utilize with patients when you take care of them to understand that kind of explanatory model that patients are coming to you with. And I don't think that asking these 8 questions is the answer or necessary for most patients, but I think having this sort of framework in mind when you talk to patients is one way of kind of getting at the heart of what explanatory model you and the patient are both coming to care with. And so I use some of these things in a general way when I talk to patients. So I think about asking them, what are you worried about? I think about asking them what kind of treatments that what kind of treatments they're expecting. We talk about, we over time have offered patients much less surgery. And I think I have found that patients are sometimes come in expecting surgery from you. And when you don't offer it, that can really create a lot of confusion. And I think understanding where they're coming from with what kind of treatments or what they think they need to be better can be really helpful. And then I think number 8 is one that we can we can also utilize the most. We can utilize really well as well as what do you fear about illness, right? It allows us to tailor the expectations of the patient about illness and treatment to that particular patient. So I think in a lot of ways, I have always thought of being a surgeon, being a doctor as being one specific thing, and my interest in anthropology is being very separate. But in putting together this talk, I realized that a lot of the things that I learned as an anthropology major and doing anthropology research and afterwards was that those things have really become part of who I am. And I think understanding what we think about ourselves as surgeons and what we think about as our culture, even if you don't think about it in that formal way, is really helpful in interacting with other surgeons, other physicians, and also with your patients. So I'll leave you with a few, I can't help it, with a few anthropology readings. I didn't include anything from this book because I know Anna was talking about women in surgery, but The Woman in the Surgeon's Body by Joan Castle is really, really excellent. Making Doctors in an Institutional Apprenticeship by Simon Sinclair is a full book ethnography that he wrote after an ethnographic study in the NHS in the UK. It's actually really interesting from the 90s. And then Pearl Katz, I talked about her Rituals in the Operating Room paper, which is part of a full book called The Scalpel's Edge, which is also really interesting. And then Arthur Kleinman has written many books, especially about healing and suffering in the context of culture and healing. But he also wrote recently, within the last 5 years or so, The Soul of Care, which is a book he wrote about caring for his wife as a physician and as an anthropologist and as a husband as she developed Alzheimer's and succumbed to Alzheimer's. And it's a really beautiful book if you're interested. So then I'll just transition into a little bit about me. So I grew up in Fargo, North Dakota. I had a really happy childhood, obviously. It wasn't just me. I had an older brother, which this is my favorite picture of my brother because he looks so sweet. And then he was also the one who used to tackle me and put me to the floor as a child. And then came along my sister, who I'm carrying probably the way I still would carry a baby now. And so here's with my mom at my grandparents' house. And as you can see, I had excellent style from the very beginning. What you can't see are my raspberry colored high top Converse with Bugs Bunny on the side. But I grew up in Fargo. I lived there my entire life. I have 3 siblings. My sister is there in the white dress, actually the white dress in both pictures. She is a aeronautical engineer. She just finished her 2nd master's degree and works at Northrop Grumman doing something that she can't really tell us about, and working her way to being an astronaut. My brother in the middle is a psychiatrist. So the boy that used to pin me to the floor and like spit in my face now he's actually very appreciated in his department because he certainly does psychiatric medical management, but he also has a passion for psychotherapy and so does a lot of that with his patients and works with patients that are really difficult. And I know that and I really respect how much he puts into his patients. And then here you can see that's his wife, Stephanie. She's a reproductive endocrinologist. They met in medical school. And so then when I was in medical school, they had Maggie there in the bottom, who is my first niece, and then Millie, and who's, I'm pretty sure, going to be a surgeon based on this excellent costume that she had last year. And then they recently had added George there in the middle. And so it's been really, really fun having them as a distraction during medical school and residency. My parents have been a huge support to me, especially my mom. She would come up during COVID and I'd be at work all weekend and she would come to my apartment and cook for an entire day and fill my freezer with little boxes of things for me to eat. And so they go out of their way to be supportive in both sort of emotional and physical ways, which is I really appreciate. I worked before I went to medical school at the Children's Hospital in Philadelphia, and I did pediatric orthopedic surgery research. So I have a lot of very specific knowledge about things like vectors and growing rods and multiple hereditary exostoses that serve me no real purpose at this point in life, but it did give me wonderful friends. These are just a handful of the girls I worked with in our office, and we've continued to get together. My friend Michelle is a radiologist. My friend broke the glasses right behind me is also a psychiatrist, and Ashley is doing a master's in public health. Or actually, she's going to be doing a PhD in public health. So she's one of the few of us that got away from medicine, but is also doing great things at Penn. I have friends from college that I would be remiss not to talk about, who have also been a huge support to me. And Stephanie and Lizzie have been my friends for 20 years now, and so I really appreciate them. And then Kristen, who's the blonde in each of these photos, is a friend of mine from elementary school. And some people have heard me talk about her before. She actually passed away my first week of residency. And I think about her a lot when I take care of patients. She actually passed away from a massive PE off of a PICC line that she had, getting antibiotics. And I talk about her and one other patient that I took care of my first week of residency, because I think she reminds me to not do things that don't matter, to not do things to do only and order only for patients the things that they really need. Because even something as simple as a PICC line can have devastating complications. She was actually a nurse. Her mom was a nurse who she was living with at the time. So you would think that of all the people for something horrible like that to happen to, certainly she knew exactly how to take care of a PICC line. So I think about her a lot, and I'm sure all the interns have heard me tell them when they order lab draws that I don't think they need, or any other intervention, to just really think about what we do, and because even small things that we do can have consequences. And then not least is my boyfriend Justin. So he puts up with me. He's become a theater geek along with me. You can see us there with Nathan Lane last week in New York. But he's a huge support to me. Here we are at Buc-ee's. And he goes along with all of my silly ideas, like buying an 8-foot tree for our apartment here in Minneapolis, and cutting it down himself, because why not? And driving to Sherburne to eat dinner at like this tiny little place 2 hours away, because they're supposed to have amazing food. But he literally makes me lunch every day, so that I don't eat a cheesesteak and Diet Coke. He makes me a real salad every day, despite what you'd think from this giant cinnamon roll. But he's been hugely supportive over the last 6 years. We met the first week of COVID, and our first day was like walking around the lakes because you couldn't go anywhere else. And so I really appreciate him. So I went to medical school at the University of North Dakota, and a pretty small class, relatively speaking, but over half of our class was female. And we had, even for a small school of about 80 of us, that focuses on family medicine, almost 20% of us went into surgical fields. So we were really well supported in our interests, which I really appreciated as well. And it's also where I met one of my best friends, Rory. We met because we have alphabetically ordered names, and so I met him in the photo line to take my photo my first day of residency. We've been together since, watching Stanley Tucci while his dog Reese licks my leg. But he started out as a surgery resident, and actually quit and transferred into anesthesiology, and is super happy with his change. But I really respect him, and he's always been a huge support to me as well. And then just to kind of wrap up, not everybody knows, but I think a lot of people do, that I actually didn't start residency here at the University of North Dakota. So I actually started residency at the Hahnemann University Hospital program in Philadelphia. And this is my original intern class, and then our 3 female residents. And then this is the entire, what ultimately ended up being final residency program at Hahnemann. So 3 days into my residency, we found out that the entire hospital system was closing, and we were going to become what's called an orphan residence, which is about as terrifying as you might imagine, because you think you've done all the hard work, and then you realize that you have no place to train. But I was lucky. Dr. Brunsvold actually reached out to everyone in our program and said, "Hey, if you're interested in coming to Minneapolis, we probably could take some senior residents because we have lab residents." And so I tentatively emailed her and said, "What about an intern?" Because I had interviewed here and I had really liked it. And so I actually met with her and Dr. Acton on Zoom from one of the tiny dark hall rooms at Hahnemann, where the walls were collapsing around us and reps were coming and taking back their joints and stuff like that. And we were hoarding supplies to take care of our patients. All of which is true. And so I'm really grateful to have started residency with this intern class. We still keep in touch. Actually, Colleen and the Glasses just matched in a pediatric surgery fellowship. And so we still support each other, even though we were only residents together for about 5 weeks. But ultimately, I came here to you guys, which I'm very grateful for. So my intern class to my chief class, it's been a joy to be with all of you. I look back now and it's hard to imagine being a resident somewhere else for these last 7 years. So I'm really appreciative of being here. And then a special shout out to Shelby, even though she's not here, because she's become one of my really great friends here in residency, and we traveled to Taipei together, where I promise we actually did see. We actually went to a conference and presented and met some fun along the way. But really, I'd like to thank everyone here for taking me in again as an orphan resident and making me part of the program. Dr. Brunsvold and Dr. Acton, who kind of started that out. I worked with Dr. Melton Bukes during my clinical informatics fellowship, and that's been really instrumental in sort of reminding me about some of the non-surgical things that interest me, and helping me realize that there are other things that I can incorporate into my practice other than just surgery, and that can be really fulfilling. So I don't have any pictures. I assume Dr. Acton knows what he looks like 10 years ago, so I didn't put up any of those photos, but I do really appreciate all the attendings that I've worked with, all the APPs. It's been really a joy to be here. Thank you.
Thank you. This is really interesting. I think just talking about, even like you mentioned, the culture of surgery and the roles that we take on. Thank you for being such an amazing chief resident. We did Regions EGS together, and you were very patient with me through all of the horrible gallbladders. And despite how frustrating I'm sure you were and I was at the same time for how awful they were. So it's been great, and I can't wait to have you here next year as well with the critical care fellowship. So thank you for all your help.
Thanks.
Quick question, Melissa. I loved it on the aspect of anthropology, because I've always thought about, because surgery certainly does have a culture.
Mm-hmm.
There's several little subcultures within
Sure.
surgery. Sometimes when we're out and we're talking with our non-surgeon colleagues, they have their culture, and they often view our culture as the one that's wrong and the one that needs to change and adapt and become more like them. At least that's the impression I get talking with them.
Yeah.
Have you felt the same, or is there anything in the literature that, how do you define that one culture is better or worse? Because that's where our brains go as humans.
Yeah.
Even though we can't sometimes accept that they're just different, and they're going to be different.
Yeah, I think that's. I think I would agree. I have felt that of this idea that, like, there's some that I think I don't know that I've always felt that other other sort of specialties or other physicians feel like our culture is wrong or the way that, but I think they have a sort of stereotyped picture of what our culture is. I think it's sort of, they sort of view us, I think a lot of times in that sort of dichotomous other of these people that like act and we don't think. And so I think as we have become more, I think surgeons have become less dichotomous in our thinking, and we often, I always think about it in this phrase of like, we're not just the technicians, right? I think sometimes, I think that's what that like, the surgeon and the internist as others to each other, and I think that's where that sort of comes from. And so I think, you know, anthropology at its root has always been about understanding other cultures, and I think that's I think the takeaway is that you have to recognize your own culture to appreciate anyone else's, and by sort of coming into the ideas of, as anthropology has evolved, of cultural relativism into you know, postmodern subjectivity, is that there is no I think I don't agree with the idea that there is no objective truth. I think if you look at epistemology, that there's an argument against that. But I think taking your own culture as a reference point, but not as the be all end all, is really the takeaway, right? It's how we interact with patients. The way we think about how to manage something isn't. Sometimes there's an objective truth, but I think we all know that often there isn't about how to do something. And so I think it's really about trying to appreciate the culture of sort of the other.
I agree. And I think I look roughly the same as 10 years ago. I don't know. Probably hair's a little more gray.
Well, then you definitely don't need a picture of yourself up there.
So I have a comment from Dr. Kendrick, that he wants you to know that we're lucky to have Hahnemann so close we could brag about her being from Minnesota. Her clear-headed, pragmatic approach to all things clinical have made her a calm leader and stands in great irony to the impractical side of her, like putting an 8-foot tree in her small apartment and driving 2 hours away for the best hot dish in Minnesota. Thank you for your commitment, and I'm excited to work with you.
Thank you very much. I appreciate that.
I'm last man standing. Everybody know what they're supposed to do?
First man
After conference, first man standing.
We have Dr. Jensen for core curriculum, but it's scheduled to start at 9. So eat the rest of the food.
So when you texted yesterday, I was thinking of
Game time.
I saw an IDP. So that was how our morning.
Maybe I took it to Zoom here. So there is no reason why.
Oh, yes.
The answer, unfortunately, is me.
Alright. You're gonna love Methodist.
Well, no,
The only thing that freaks me out.
except for that I and I will be working for like so like working for 30 days straight, that sounds awesome. Yeah, I'm doing that for like 10 days now, and not like 2-3 weeks like.
You never know as part of it. Makes sense, actually, because it's probably
That's rough.
doesn't like
And this club is
be
I don't want this. Yeah, I was like,